Good evening, everyone, and welcome to this evening's meeting of the Health and Wellbeing Board Community Subgroup. I hope you all enjoyed the summer because it looks like today signals the end, but hopefully we'll still have a lively meeting nonetheless. So to kick off the agenda, we first have apologies for absence, and we have received apologies from Rob Clark and also from Mohan. I don't think we've had any others unless there's anyone else want to raise? Nope. Okay. And then just moving on to declaration of pecuniary interests. Are there any declarations? Nope. And then just minutes of the previous meeting on the 27th of July. Can I just check that everyone's happy that these are an accurate record? Great, I see thumbs up from Una, so happy with that. There were no matters arising, so we just move into the first agenda item, which is the COVID update. And as usual, we'll start with a overview from Dagmar. So I'll just hand over to Dagmar.
Great, thanks very much, and good afternoon or evening, everybody. I've got a short and sharp update, only one slide today. So if you wouldn't mind moving to that overview slide, Clarissa. So key message is that infection rates are hovering, and they are actually hovering at quite high levels. We got a bit used to them. So between 200 and 250 per 100,000 per week. What you can see around the R level, that always tells us, is the epidemic leveling, or is it still growing? It is around the 1 mark. 1 means it's steady. So you can see the range is just 0.8 to 1.1. So that chimes with what we see in Merton. What we're obviously always looking is what's the impact. We use our NHS data for that. Admissions actually are sort of modestly sneaking up. I've just had a meeting yesterday with our NHS colleagues. Not unsurprisingly, the main people in hospital were unvaccinated people. These are younger cohorts. The encouraging features were that admissions weren't rocking up to the same level as we had community infections, so clearly the vaccinations are doing their job. Also, the severity of the illness, admissions are still happening, but ITU admissions are very much lower, and the best news is that fatalities are really staying very low. There is a bit of a niggling, so this is at the moment anecdotal, but we are obviously keeping an eye. But our NHS colleagues say there are now older people coming back into hospital, and some are fully vaccinated. So there are obviously proper studies and proper surveys monitoring that very clearly. Chimes a bit with what you've probably heard this afternoon in terms of the announcement of the winter plan, Plan A and Plan B. So vaccination is the best tool we have in the toolbox, and there was the confirmation of the booster. So for people already fully vaccinated, having a booster 6 months after their second dose, and that should deal with some of the observations about the breakthrough hospital admissions. The big unknown is that the schools are back. They have been back a week or so, so it's a bit early to see any impact. It's basically the combination of schools coming back, weather getting a bit wetter, at least not yet that much colder, Rebecca, that makes people slightly nervous. And I think it's fair to say precautionary approach. We really do not know which way it's going. We have started to see outbreaks again School policy obviously has changed, with a real emphasis of continuation of education, because the health of the kids is very rarely impacted badly. But again, the announcement of the vaccination for the 12 to 15-year-olds helps also with during the winter managing potential increases and disruption. We're continuing with the testing, and there's obviously a bit of fatigue, but really important. There's a big emphasis still, if you have symptoms, you must test. It's not a new news. We have to keep reinventing it to keep it relevant. And for the time being, the regular use of the lateral flow tests for asymptomatic people who are out and about, and particularly in workplaces, is still recommended. So I leave it at that, and open to any questions.
Thank you, Dagmar. Are there any questions for Dagmar on that update? I had just one, Dagmar, just around the booster vaccinations. I suppose we don't know a huge amount yet, but I wondered whether there were any plans already on how we might approach that across Merton.
So I don't want to preempt and steal the thunder. We've got Julia and Kate and our CCG colleagues. I see Mark in the room, and we've got quite a bit of a vaccination topic. I think it's very hot off the press, but the NHS is obviously already lined up the ducks in terms of delivery planning. But rather than preempt, we are now sitting tight to receive further guidance. So that would be my approach. What we can assure the subgroup is that we are very closely working with our NHS colleagues already behind the scenes to get the ducks in a line. But it is quite complex and complicated. So the comms around it, we're very keen that it is really consistent. Otherwise, it can be very confusing. It's a bit of a wishy-washy, sorry for that. My colleagues might want to chip in and do a better job.
Mark, did you want to come in?
Yeah, certainly not to do a better job, but just to say that obviously Kate's doing something around equity later on the vaccinations. I just wanted to say, in terms of the 12 to 15-year-olds, that my conversation today with an adult who's kind of heading up the Southwest London team is that we are planning to have borough-based conversations with head teachers, yeah, so that we can really try to support schools in carrying out this quite complicated and quite contentious kind of activity. So it's just to say that over the next week or so, we will be seeing sort of a kind of coming together of us all to try and support schools in doing this.
Thanks, Mark. Una.
Thank you, Dagmar. That's a great update on it all. Just turning to the testing, I know that according to those figures, we seem quite, I think we were rated third in Southwest London boroughs for testing and so on, which obviously is great. But what's our sort of policy carrying on? Is there still going to be the big focus on testing? Because to date, I think that's been particularly helpful, hasn't it, really, in allowing various things to continue. But I'm just wondering if that is. And also, there's quite a lot of angst around people wearing masks or not wearing masks and social distancing and so on. So I just wondered whether we were going to be giving any advice alongside that. Thank you.
Yeah, so if I talk about the testing first, I absolutely agree. I think with the endeavour, and this group played its part, stakeholder engagement, we've managed to get really good testing testing levels and high uptake. At the moment, there is no plan to change that. We are obviously always keeping an eye out for potential change in policy, but the main thing is that we're still getting the tests, and the tests are free. You will remember that there had been some considerations longer term, how long that will be an offer for, but at the moment there is no indication that there is a change. So I'm looking to this group and your good help. I'm delighted that when we're talking to our young people later, testing is also and has been on their mind, and they have been very helpful in persevering with the promotion. So that's the basic sort of bottom line. Go for it.
Is the advice still to continue with twice a week?
Yes.
Yeah.
Yes, absolutely. And we have just had a discussion earlier in the council as well. So for our smart hybrid working, one of the promotions is 2 times a week LFT use when you're out and about. So absolutely. We need to be considerate that there's no mandation anymore for social distancing or face coverings. There are specific situations, so you will be aware Transport for London is mandating face coverings on public transport, and we obviously therefore very much promote adherence to that. And the recommendation in terms of civic duty is judge well if you're in a crowded place, if in doubt wear the face coverings, but that is obviously civic duty rather than a mandation.
Thank you.
Thanks, Dagmar. And Vasa.
Thank you, Chair. 2 important points arising from what Dagmar just said about testing and masking. I'll go with masking first. I think there is a lot of misunderstanding and ill feeling at times in the community because it's no longer mandatory, but people forget that in healthcare settings, we still advise people to kindly mask because vulnerable people do come into our building and asymptomatic people do spread despite being double vaccinated and very mildly infected with the disease. So to keep that message going is hard work from a receptionist point of view in the practice, because people never rarely shout at me, but sadly in England, people do shout at my receptionist who's not as well as remunerated as I am remunerated for whatever shouting I had to receive as part of my job. So I think we need to use this to explain to people that the receptionist is not being harsh or hard or making it up as she goes. She's actually doing what she's supposed to be doing to offer people masks who come into the building without a mask. But there's a limit to the number of masks you can hand out as well, because the mask is not being given to the practice to hand out to people who don't come with a mask. But that's what we do, and that's what we have to do to maintain IPC in our waiting rooms. And that other thing, Dagmar, we got to go on talking about this testing, the difference between asymptomatic people getting lateral flow and symptomatic people getting a PCR. From my part of the world, you can't miss the white tent in front of Merton College unless you can't see white. Then of course you'll miss it. But it's such a big thing, so it's very easy to spot it where it's located in my part of the world. So, and as long as it's located in an easy place and people can see, then those of us who believe in the PCR, which should be all of us really, we should be continuing to advocate symptomatic people through our COVID champions, that symptomatic people should carry on going for PCR, the only sure way of knowing whether you got the disease or not. And now it's very stale, it's very old, and some people think this is archaeological information now, but unfortunately, it is still current, and this is the only way we can actually get on top of it and move it from a pandemic into an endemic level of infection. But if you don't ignore it, then we'll keep it as a pandemic for too long.
Thank you, Vasa. Barry, did you want to come in?
you, Rebecca. Just to kind of respond to Vasa's point there about the lateral flow testing, as Dagmar mentioned earlier, we're continuing that approach to encouraging uptake on a regular basis. We have a target group for those disproportionately impacted groups, and we've recognised and we've spoken to our communities. And so rather than just 2 fixed testing sites for asymptomatic testing, we're piloting pop-up, so learning from the vaccination programme to rotate and move around the borough so it's even easier for people to take a supervised test and then to take test kits home with them. And the really interesting and helpful product change is that the new test kits that we're now getting in the community are double nasal swabs rather than nose and throat. And that's going to remove a significant barrier to hopefully many people within the community. But proactive approach, moving around the borough to try to deliver where we possibly can. So again, subgroup members, if there are any opportunities that you see that you think testing could fit really well in, please let me know and we'll be happy to take those forward.
Thank you, Barry. Were there any final questions or comments for Dagmar? No. Okay. Thank you, Dagmar, for your presentation. And I now think we are welcoming Heather to the group, who will tell us a bit about a couple of COVID-19 grant funding streams. So I'll just hand over to Heather to introduce herself and the funding streams.
Thanks ever so much, Chair. Yeah, so my name's Heather Begg. I work in adult social care as a commissioner, but 2 of the things I lead on predominantly at the moment is the Merton Carer strategy and also oversee the local community response. So hopefully you've had a chance to review the short paper for this agenda item. I'll try to summarise as quickly as I can. As you know, over the last 18 months has highlighted the inequalities that already existed in Merton, with residents having even greater impact on their lives. So it's great that we've had such a strong community response to supporting our residents with the help that they have needed, in particular for our most vulnerable, isolated and disadvantaged residents. We're having regular monitoring meetings with our local voluntary sector and community organisations, and I'm sure they've probably presented at this subgroup previously about this. And we join up as a community response network once a month to highlight these key issues. We therefore know what services have really been under pressure due to the increased demand over the last 18 months. Fortunately, we've received additional funding to the value of over £500,000 from the government to help with practical support for people who are self-isolating, and in addition, our clinically extremely vulnerable residents. And just to remind you that there are 14,000 clinically extremely vulnerable at the last count in Merton. So we've used the data and intelligence we've gathered to fund additional capacity across the voluntary sector for local organisations to provide more support where it's really needed. And also mechanisms are in place to monitor the outcome of these grants. So this has included more carer assessments and increased carer discretionary grants. Carer assessments have significantly increased the demand for them over the last 12 months in particular, and we're seeing that continue to rise. I think also because we've launched the carer strategy, we've also raised the profile of carers locally. So actually we needed to make sure that we had some additional resource to support that. So that's been really good that we've been able to use the grant for that. We've also provided additional capacity for our existing befriending and volunteer coordination. As you can imagine, when you have lots of volunteers, it takes more coordination and support. So we've been able to bolster there. We've increased the capacity for citizens' advice, particularly at a time where the demand for support from citizens' advice is really significantly going up. And further funds to the wider voluntary and community sector via Merton Giving. We've been able to also provide funds for additional community accountancy and monitoring to ensure that those smaller organisations receive support to bid for desperately needed funds. We're now going to be talking to some of our local CV residents as well. So we have some plans in place going forward to understand further what we can do locally to support people who are continuing to struggle to access their local community. So we've set aside some funds for that. So we want to hear from our residents first before we assign those funds, but also holding on to some funds to provide additional food support if required over the coming winter. So that's it from me, Chair. I'm just happy to answer any questions that anyone has.
Thank you very much, Heather. Are there any questions from the group? Una?
Yeah, and thank you for that report. And I found it very interesting. And in the main, I think it reads really well. And it's great to see in a transparent way the amounts that have been already given out and proposed to be given out. But I do know that you're still planning to retain, I think you say at 0.5, a balance of it's nearly 71,000. And I just wondered if you could comment a little bit more as to how long you're planning to hold on to that. Obviously distributing it is important, isn't it? So just wondering whether
Absolutely
do that.
I have no desire to hold on to this money for any longer than we need to. The really important thing about this money is that it's gone straight out to the voluntary sector, and it's gone out quickly as well, but we need to understand exactly where it needs to go. And I think recently we've had some listening sessions with some of the community champions who have been shielding. They've been shielding for a very long time. They've continued to shield for the last 18 months. And we've actually had some specific listening sessions with them. And it's made us really think about actually maybe there's something else that we need to do. So myself and Barry have been in conversations, and I know we're setting up some additional listening forums for clinically extremely vulnerable residents. We'll also be having a letter go out quite shortly to those residents as well, just to really understand what that support looks like for them. We believe that we've got a lot of practical support available, and obviously I oversee the Community Response Hub, so we know we've got that practical support. If people need that support today, tomorrow, they can get it. But it's actually something a bit more long term, I think, that actually people are needing support with. So yeah, but we really want to spend this as soon as possible. So I would say certainly within the next couple of months that money will be allocated.
Thank you. And will you just report back at some point?
Absolutely, happy to. Yeah.
No, it's very interesting, so, and very helpful to see it. So thank you.
Thanks, Una. Mark.
Thanks for that, Heather, and that was really useful. I think it's just it's a plea really that within health services we also do some community services grants, and actually post-COVID we are looking at how we can do that. So there may be a conversation we might want to have. I'm sure Barry and you've already had it with CAS, etc., but just perhaps joining up and maybe getting more bang for our buck, so to speak.
Absolutely, and perfect timing really, because we have a meeting that it's actually scheduled for next Monday to talk with CAS, myself and Barry, about just that. I think we may have to reschedule that, but that is also with Merton Connected, and it's very much also looking at some of those more marginalised communities and seldom heard voices, to make sure that we're having a real fair and as equal as we can distribution of these funds across the borough.
Fantastic. Thank you for that, Heather.
Okay. Dagmar.
Yeah, and then very finally, so big thanks, Heather. Really good work tuning in. So precisely what this group is about. Also the linking up with the mental and emotional well-being support that is sort of available, because a lot of what we've in a way find now is residual anxiety. There is no more real situation for the clinically extremely vulnerable, but we've labeled them. and they have lived in that situation for so long. There is really quite a lot of anxiety that in a way we have created, that we now need to really support to alleviate.
Absolutely, totally agree. And yeah, so I think actually, Barry, you were going to present something quite similar to the Mental Health Programme Board, particularly looking at clinically extremely vulnerables at the next meeting.
Thanks, Heather. And just one comment, it's just really nice to see after we had, just thinking of Age UK and also Merton Mencap report to us on some of the challenges that some of the people they support have faced during the pandemic. We obviously heard a lot about sort of digital exclusion and challenges with digital access. So it's really nice to see in this report the IT equipment loan scheme and supporting with digital skills in particular. Thank you, Heather, very much for coming today and presenting on this, and we look forward to hearing how these go, and also the remaining spend and what that goes on.
Lovely, thank you everybody. Okay.
And our next item is on vaccination and specifically focus on action on equity. So I'll just hand over to Julia and to Kate to both introduce themselves and update on this item.
Thanks very much. So if I introduce myself, I'm Julia Groom. I'm a consultant in public health with the Merton Public Health team, and we're going to do a bit of a double act with Kate. Kate, do you want to introduce yourself?
Thank you, Julia. And I'm Kate Simons, and I'm the Deputy Director for Primary Care Transformation for both Merton and Wandsworth boroughs.
Thanks. So I'm going to kick off and then hand over to Kate. If we could have the next slide, please. So earlier this year, this board reviewed and commented on our vaccine equity framework, which is the approach that we put together with all our partners to look at how we can promote equitable vaccination uptake. It's a simple framework focusing on reducing barriers to access, communication and engagement, partnership and governance, and making best use of information and data and insight. And I think this board made a really valuable contribution to shaping and refining that. So what we want to do today was really give an update on some of the data, some of the work that has taken place, and really have another discussion with you around what the next steps are to our work around vaccination equity. If I have the next slide, please. So I wanted to start with a look at who remains unvaccinated in the borough. As Dagmar highlighted in her slides, we know that over a 250,000 vaccinations have been given in Merton. So there's been an absolutely mammoth effort since we put the vaccination plan together. We know, though, that 56,000 residents still remain unvaccinated. And we've looked at a number of domains to see where those groups are that are least vaccinated, have not taken up the offer in the way others have. So you probably will be familiar with these, but just to update on some of the figures. So we know that younger people in the borough remain less vaccinated. So 41% of people between the ages of 18 to 39 remain unvaccinated, and that's over 27,000 residents. And that compares with 36% of working age and 13% of people over 65. So you can see we still have a large cohort of younger people who are not vaccinated. If we look at geography and deprivation, the pattern remains that there is lower levels of vaccination uptake within the east of the borough than the west. And we know there are particular communities that remain where we have high levels of deprivation and we have lower uptake. So you can see there Pollard's Hill, Figs Marsh, Graveney, Lavender Fields, all those neighbourhoods where we know we have lower uptake, and there's been a huge amount of work with our pop-ups, which Kate will touch on to try and make access as easy as possible, but they still remain areas with lower uptake. If we look at ethnicity, We know that vaccination uptake is lowest among Black ethnic groups still, so that remains among the Black Caribbean, Black African and Black mixed groups. And we also have lower uptake among what's termed other white other ethnic groups, which includes our Polish and Eastern European communities. There has actually been only a small increase over time in the proportion of a vaccinated population among ethnic groups. So there hasn't been much change in those proportions over the time of at least the last two or 3 months. If we look at age and ethnicity, so we've taken a snapshot of people aged 20 to 44. Sorry, I just have to move my slide slightly. 20 to 44, and we can see that in that group, 61% of Black ethnic groups are unvaccinated, and that's over 4,000 residents. And then in the white ethnic group, we can see that I think it's 53% remain unvaccinated, and that's over 13,000 residents. So you can see there's a really significant number of residents in that group where I think we need to work with communities to really look at what are those barriers. I know you've heard from community groups, you've heard from BAME Voice on the research and the insight work that's been done with different communities. So there has been a lot done locally. I just wanted to touch on some of the insight work that we've heard from our London and national colleagues as well. So if I could have the next slide, please. So yeah, what are the causes of residents remaining unvaccinated? Well, on the left of the slide, these were the barriers that we identified in the vaccination framework earlier in the year, which ranged from practical access issues through to safety, not wanting to be first, low perceived personal risk, fear and mistrust, and misinformation, particularly through social media. And I think many of those factors are still relevant. I think from certainly some of the London and national insight, practical factors are reducing, and certainly if you see on the right-hand side of the slide, recent insight from the GLA said that trust is the top reason for those Londoners who said they don't want to be vaccinated, so that's 45%. There's still a perception of low risk among many people, and there is still a perception around the safety of the vaccine, although that is lower among lower age groups. And then just wanted to touch on some national insight work that's done over the summer to 18 to 29-year-olds living in kind of urban and lower social groups. And really some of the factors that were highlighted there were around a low sense of personal risk and low trust being main reasons, that they're also adopting a wait and see approach, which is similar to other groups. They're questioning efficacy, so they can see people who've been double vaccinated in the press still having COVID, and they're questioning that. And that practical barriers are actually much less of an issue now. So it's more about those issues of trust and engagement and evidence about the safety. So I'll pause just there, and if we could have the next slide, please. So we wanted to move on to what we've been doing, and I'm going to hand over to Kate, who's going to give a quick run through of some of the huge amount of activity that's happened over the summer.
Cool. So I think I'm not going to go through all these slides. So I think this kind of gives an example of all the things that we have been doing, a number of the kind of comms and media bits that we've been doing as well, which is really key. I think everyone, if you haven't seen something to do with COVID or getting yourself vaccinated, either on social media, I think that's been really key. And I will touch on this in terms of the specifics on the next slide, in terms of some of the specifics. So if we can move on. So what have we been doing? And I think that's really key to pick up some of the insight work and how we've been challenged in terms of trying to increase those vaccination rates and those numbers. So I'm sure you're all aware already of where we've had the vaccination programme, but it's worth reminding everyone that it was delivered and is being delivered in a variety of settings. So our PCN local sites and the larger mass vaccination sites and through community pharmacies. And I think it's always really poignant to kind of draw out that has been hugely complemented with a really targeted community outreach programme. We continue to provide community outreach pop-ups, and these are ongoing on a weekly basis across Merton. This has been driven through data. So data has been used to kind of identify either really lower super output areas where we know that the uptake rates have been more challenging, and with specific communities that have been identified. So not only do we look at the kind of specific targeting the area, but we also look at targeting communities. And we've given a kind of a range of that I've listed 4 here, but I could have probably put a list on for the complete list of slides, to be honest, because we have done and are doing continue to target a range of community outreach approaches and engaging with communities. And I think the fact that a number of communities have welcomed the vaccination group and have offered their spaces going forward is a testament to how the local community is supporting our vaccination programme. I should also say that all of this has been kind of complemented, and this is really up to what we call the sprint, so the 19th of December, by a community outreach programme called a door-to-door approach, which supported that, and whereby we had over 1,500 local resident addresses identified where we had lower uptake, and those areas were leafleted, and we provided a door-to-door team who would then kind of approach those households to discuss the opportunity to be vaccinated and to also signpost them to the local community outreach. So I think that's a flavour of the huge amount of work that we've been doing to help and provide vaccinations to a wide cohort of people. I think it's clear that there's more to do in terms of what next, and we can pick up the evergreen offer. So I think that's actually key when Julia talked about how we increase equity, is about how we continue to provide access. We do make sure that we've still got easily accessible venues. Of our vaccination clinics currently continue to be walk-in. They're also booked by the national booking system. So we've kind of are planning on reducing as many barriers as possible to allow people to access. And as we move down that cohort into the younger cohort, we were very mindful that actually people access vaccination in a very different way. The local team are actually trialling Eventbrite at the moment, because that's been a different method that we've been able to get different people vaccinated. So I think that's really key. And I think all of this is about building on the learning that we've had going forward. So I think as we've all talked about, I think, and I probably should stop that myself and Julie weren't the only people that wrote these slides, because actually it's about engaging with the wider community, and actually this is a whole kind of co-production approach to everything going forward. And as I said, and I'm sure Dagmar would agree, that we need to make sure we make the most of the data that's available to us as we address how we take the programme forward and how we work with community groups and our outreach model going forward. Next slide, please. So talking about communication and engagement, and again, this is just a tiny fraction of the work that has taken place. It's been led through a number of colleagues through our communication teams, both at CCG level and the local authority. We've had our engagement leads at the local authority and the boroughs, all working to deliver a huge range of plans and approaches to target all of the cohorts throughout the programme. So I think this just gives you a really high level of some of the bits and pieces we've kind of been delivered. I think key, like 66 programmes reaching over 1,300 Merton residents. We've got our community champions, and we've worked with a huge range of our local communities, and actually it has been driven by the insight work, but this is just a small area to show the digital marketing actually, and I know there's a number of colleagues on the call about this, in terms of being able to target our approach has been really key. We've got a number of cohorts of people that need to get vaccinated, and we have been able to drive our messages to the right people, so I think that's been really important. I think it's as Heather talked about grants, I think it's really important going forward that we continue to utilise working with our local communities and strengthen their approach. We do have a number of channels and opportunities to work with our local communities, and on the section on the right hand side we talk about some of the different ways we're already providing skilling up and allowing communities to have the voice. I think that's really key into this bit. I think as we talk further forward, and I think what Julia pointed out is vaccine uptake rate now isn't a practical issue. It isn't about putting on more in even more spaces. It's about empowering people, and it's about encouraging and empowering and educating people. And actually what we need to do next is work with those groups to ensure that we're delivering the right messages, but so that they can deliver the messages going forward. So I think that's our kind of next phase about how we continue to communicate and engage. Next slide, please. I think this, I will pick up actually, Chair, your Rebecca, your comment as well about the vaccine programme in a bit of this. So I think we've all kind of got to we've all understood that this isn't going away, and we do need to think about how we embed the programme going forward. I think in the next phase, as in terms of phase 3, we need to consider what we have to deliver and how we might, what the challenges are. So I think we've already referred to phase 3 and the booster programme. I'm desperately trying to catch up on the news as it comes through, because I think we'll get the details as we're probably speaking now in terms of the actual devil in the detail. But I would, as Dagmar said, I would like to provide the group with further assurance that we have been working on phase 3 and planning for phase 3 for a while now. We have a number of local Merton sites that have already been approved to go forward with phase 3. So we just need to get the kind of final detail. So I can tell you right, that the Wilson and the Nelson will be our local sites as part of a PCN delivery model. We still need to make sure we combine that with our mass vaccination sites strategically and our community pharmacy sites. But I think just to say that from a primary care perspective, we already have our sites that are well established and have a team of people in place that will be there ready to deliver the programme. Obviously, the links to the flu vaccination are going to be key. I think they're a key and a challenge, both parts actually. We would, in terms of the delivery mechanism, but also the opportunity to vaccinate people in one consistent approach. So I think those are really kind of an opportunity there as well. We've talked about the evergreen offer, and I think that's really key to this discussion in terms of ensuring that not only do we focus on the future, which is the booster programme, but that we do need to remember that we still have, as Julia noted, a large proportion of the population that still needs to be vaccinated, and we do need to provide them with an opportunity to be vaccinated. The healthy 12 to 15-year-olds, again, this is coming out as and when we, and we've talked about that, but this is coming out as we speak as well. I should say we are aware, obviously, with the school nursing offer at this. I will add that we are looking at, because obviously we're looking at complementing this with a local primary care offer as well. So the idea may be that across Merton, we do have one hub that also supports this delivery mechanism later down the line, just so that we're aware that actually, should we need something, or should we need something across the borough that helps support the delivery, then we have people in place and a system in place to support that should we need it going forward. So it's all about us putting bits in place and getting ready to deliver things and making sure that we have systems and processes available should we need them. Again, pharmacies around, and again, the integrated vaccine offer. And the one-stop shop, I think, is the kind of next thoughts about how do we utilise every contact? How do we make sure that actually, and I know Dagmar's got some really exciting opportunities, possibly up her sleeve, in terms of what we might want to do, engaging people and at the right time, and how we get people vaccinated. I'm not going to go into all the challenges, but the lack of clarity seems to be the main one. I'm hoping that by the end of this, we should have more information and we do have the clarity on the delivery. I will also say that the capacity and the challenges are quite real. We have to deliver the booster programme. There is the 15 to 12-year-olds, not necessarily delivered at primary care level, but across the system. And there's also the evergreen offer. So we do need to think about, in terms of the support, how we make sure that staff are resilient and that the programme's resilient going forward. So I think that's really key. And again, I think it's making sure that the well-being of the population is important, but also the well-being of our staff as we deliver the programme going forward. I think that's probably it from me. So I'll pass. I think the next slide is taking that all into account. And obviously, I think there are 3 key questions. And I think we'd like the group to kind of respond to, but I think there's probably more than that, and I'll obviously answer some questions as well. But it's really about, you've heard about the good work we've done, and I think there is a lot of work, but it's also how do we use that and how do we make the most of what we've been doing to kind of pick up that kind of no one's left behind kind of message and utilise that. So I think that's it, and I'll open it to the floor for discussion.
Thank you, Kate and Julia. That was a really great presentation, and really good to see everything that's been happening with vaccination over the last couple of months. So does anyone have any questions to Kate or Julia on that presentation? So I have an initial question just on the approach that you're taking to date. You're obviously looking at lots of different ways to reach people. And I just wondered whether you've seen particular successes with certain avenues. I know you did sort of a door-to-door approach, and it'd be interesting to hear how successful that was, or how people reacted to that.
That's a really good question. Thank you, Chair. And I think some of that did say we'd utilise some of the learning. I think what we've learned from the door-to-door approach was, so I think I talked about it last time, the approach that we initially implemented, and it was part of the sprint approach, was very much a parachuted company in to kind of deliver that door-to-door approach. It was okay, and I'll be honest, but I think what we've learned from that is actually the message does need to come from local groups and local communities. Actually, that's the key bit that we need to know. So actually, it's great that people can talk about it and give people opportunity. So there was kind of the first level of doing the door-to-door, but actually, much of this is about the trust, and much of that comes from actually local communities speaking with local groups, or local housing associations going onto an estate, and people that are trusted. So we need to build that into the future plans to think about, and I think that's part of how do we communicate more with our communities and how do we empower them, because I think actually that was key for us, is actually the message coming back was from other areas that so we, not in Merton, but in another kind of borough area, they did try that community kind of much smaller targeted approach using community groups to go in, and that seemed to be quite well received. It doesn't say that ours wasn't, but it just, we need to use that learning and empowering communities to be able to do that part of it. And I think if Barry said, I think we've got a range of kind of, the community champion, the COVID champions and other champions. And I think if Kaz from our community engagement group, part of the work that we are doing is to do that bit of work, is to empower those people and communities to be able to have those conversations to get people to be vaccinated.
You. And I suppose just sort of a follow-up question. I know you were talking about the booster vaccines and sort of the planning that's going into that. Is there an anticipation that that is going to be challenging? Obviously, people came, they were happy to sort of, well, some people were happy to have the first and then to have the second. And I suppose the expectation was that that was the end of it. And we now have the announcement of a booster, and obviously the details are being finalized as to who needs that. I suppose if it was challenging to sort of increase uptake for the first and second jabs, do we anticipate that there will be a lot more work that we are going to have to do to ensure that people are turning up for their boosters?
So I'll give you a first comment, and then I'll let Vasa kind of, I think you would say, I think there's two kind of interesting thoughts on this, because part of this is actually people came for 2, so clearly they'll want to come for 3 because they've come along the programme, or there's the other challenge is actually people just think that 2 was enough, and actually it's going to be more of a challenge to get people to come through the doors for the 3rd dose. So I think we need to kind of, we don't quite yet know how challenging in terms of getting people into the system and to access the vaccine might be. I think in the delivery, I'll let Vasa answer that question in terms of his response from a clinical perspective, but I think we do, from our kind of thinking around the programme, I think it's been, we're thinking at the moment, we just need to understand whether or not the uptake will be exactly the same, or if we're looking at something very different because of the kind of nature of how things have come across around the booster.
Thanks, Chair. Yeah, I think we can't take the public for granted. We never can and never will. And I think December is a long way different to where we are now. We were staring at death, the valley of death, literally at that time in December and January. Things were really stark. Every healthcare worker you met will tell you horror stories about that time of those 2 months post-Christmas. and society heard it and felt it from whoever they met. Now we are moved on. We are no longer in the valley of death. We are in the summer field of music shows and joy and happiness. And I think we got to understand that the world has moved on. Some will come for the third. Some will say, why? Children played a big part. When I say children, I don't mean kids. I mean children of older people played a big part. They are the people who brought their dad or their granddad to vaccination sites to get them out of the trap they were in with during the periods of lockdown, isolation. And the door is unlocked now. That is not felt as gravely as it was felt then. And also the side effects are genuine. People did have side effects, real or perceived, but people did feel some side effects, and therefore some people will have a few doubts about it. So the easy ones will come straight away. The more difficult ones, we will have to have one-to-one discussions, and that is how we'll bring them home. We will not bring them home by mass media discussions, because those people who are vulnerable but now worried whether they still need it, the equation, the risk and benefit equation, we had to explain it as an individual level, and then we'll get there. But we know from even from the normal flu campaigns we run, it's never easy. The first 60% is effortless. They are knocking on the door before the van arrives to supply. Then it's incremental, every 5%. To get the national flu campaign to 70% was never easy in the past. So we will not take even the booster for granted. And the good news from the ITU and the good news from the ward is bad news from a burning platform point of view. There is no more burning platform. We have to be honest with our patients. That's behind us now.
Thank you, Vasa. Martin.
Hello. Yeah, my question was around, I think you spoke about how there was a low uptake of the vaccine in Black, African, Caribbean, mixed, and also white other groups. I was just wondering what the strategy was for that. And, you know, are there specific, maybe voluntary groups that you're planning to speak to? And then I have another question after. Thanks.
Thanks, Martin. I didn't know if Barry, you wanted to come in to update on the grants program as our kind of one of our main strategies.
Thanks, Julia, and really good question, Martin. And again, I think we probably undersold it actually in the slides where we referred to small grants. I mean, what we've managed to pull together between the borough, the CCG and the voluntary sector is about £200,000 of investment that's going out right now into the voluntary sector organisations. There are about 13 of those organisations linked to BAME Voice, that member organisation that we're all very close to, and also the Association of Polish Families. So that gives those organisations the capacity and the time to be round the table, because they're volunteers, many of these organisations, to help us co-design some of those approaches, the messages, and to help us get the messages over, but also to help us with their day-to-day interactions to promote regular testing, the vaccination programme. So, and that's £200,000 investment so far. There's more plans, there's more conversations, and we're going to get those people around the table. But again, subgroup colleagues this evening, if there are more opportunities and organisations that we need to meet with, to discuss, to work in partnership with, as well as our fantastic network of young people, Martin, let us know if there's any more opportunities, and we'll follow them up.
Oh, can I go with my second question?
Okay.
I was going to ask about the, I think the conversation in terms of vaccination is kind of shifting towards the 12 to 15 kind of age group. And one of the questions I had was basically around who gets the final say for vaccination, whether the young person aged 12 to 15, whether they have a final say, and how are we ensuring that if they do have the final say, how do we ensure that, you know, that is fair, as opposed to the pressures that you might face from your parents to have it or not to have it, essentially. Thank you.
Who wants to answer that one?
I Hi, perhaps if I start and anyone else wants to chip in. I mean, I think it is a really challenging one. I mean, I was at a meeting with all the secondary head teachers this morning, and that was kind of one of the questions they were discussing, that actually there's a lot of feedback or coming forward from parents and parent groups, as well as young people, about how can we really reassure them about this. And I think it's to do with something called the Gillick competencies, which is whether a young person is able to make a decision. And it may be that, it's not, that isn't a fixed age. So it may be for a 14 to 15-year-old, they're perfectly capable. It may be for a younger person, they're not. So it is a complex issue. And I think we need to be really clear about the communications on this. And I know I was talking to Public Health England today and to South West London colleagues about the consistency of messages, and I think that's a really crucial one that people understand. So I think, thank you for raising that, Martin. But I don't know if Kate or Vasa, you want to add anything. Oh, Dagmar.
Yeah, shall I just chip in? I absolutely agree. You have in a way flashed out one of the really contested issues, but I can also say the first premise is that we try to bring people together. Yeah, and again, we need to be aware that there's a lot of divisive noise, but in terms of absolute numbers, this is very unlikely to be the majority. Yeah, so it is very likely that the majority will come to a agreement between the parents and the kids. There are always in everything outliers, and we have to deal with them. But for me, there is a little bit of a tendency that it appears as if this problem is the majority. And we, again, as the community subgroup, can do quite a bit to say, actually, with all the vaccination stuff, we're trying to find consensus. And I feel that is what I'm really looking at, support from Martin, your groups. And for me, there is some clarity. There is the Gillick competence issue. And if in doubt, and the young person is competent, then it is the young person that has the last word. That's sort of, for me, quite an important bottom line. But we are not playing it as a divisive mechanism. We are trying to really bring people together.
Thank you, Dagmar. Mark and then Ellie.
So Dagmar stole my thunder completely, just in terms of, because I do think it is about trying to achieve consensus, and consensus is about also providing information, so that if we know that that tension is there, working with the parents to try and address some of those concerns. And Martin, if you've got any links and networks into some of those hard to reach groups that we've talked about, because this is a collective problem, we want as many ideas as how we get into those groups as possible. So do let us know what your thoughts are, and we can pick those up and follow them through.
Thank you, Mark. Ellie and then Vasa.
Mine was short, but I've got lots of questions, but I know it's very early days with all this stuff on schools. But just to build on Douglas' point, I know it's not the same, but we did so well at working with the schools to get consent for the testing that pupils were doing. Schools were already used to communicating with parents about this. And as you say, we need to work in that collaborative, partnership-oriented way with families and build on that, and not turn it into anything adversarial. That doesn't benefit anyone.
Thank you, Ellie. And Vasa? Vasa, you're on mute.
Hi, Martin. Yeah, I think you asked a very important question there. And this thing about this Gillick competence is something which is very precious to us as clinicians, because when we began talking about vaccine uptake and why there is poor vaccine uptake in certain communities, we used the word trust, confidence, credibility. And we know that we lost it with certain communities, and we struggled in the last 18 months to regain that. And we have chipped away, and people who have initially distrustful of the system, the establishment, which I am part of. We want a lot of people over, and they have come into the vaccine arena. Now we can't now go and lose the trust and confidence of all the teenagers of the United Kingdom just because I'm on a crusade. Okay, so I can't be on a crusade. I can be evangelical, but I can't be a crusader. Okay, there's a big difference in the two. I'll explain that later another day, Martin, if the chair allows me. So on this evangelism, or vaccine evangelism, which I'm actively participating in, I got to give you respect for your autonomy, respect for your maturity, respect for your ability to listen to an explanation, understand, challenge, ask questions, and you to tell me as a young adult, I'll call if you don't mind, as a young adult, you to tell me what is your rationale, what is your reasoning, what is your feeling for saying yes or no to me. And this is a conversation. This is not a yes and no, decide today and go away or never come back type of thing. So we have to build the trust and confidence, because we dare not lose the confidence of your generation for all the other good stuff we want to do with primary prevention downstream, which Dagmar will never let me forget, for heart disease and diabetes and everything else under the sun, cancer prevention, whatever I want to do with your generation, I've lost you. I lost you forever if I buy a bulldozer and come and charge it down your road. Now, this Gillick competence is something we are used for years and years since a judgment by Lord Fraser. It initially began for a discussion on contraception, Martin, but we now use it for children for whatever purpose, whether it's drug use discussions, sexually transmitted disease discussions, whatever it may be. We don't always say drag mom into the room. Sometimes the mom drags the kid into the room. That's a different discussion. But most of the time nowadays, we listen, we explain, and we say, go away, think about it, come back. But there is no clinician who will ignore your right, your autonomy, to say no to me. I'll ask you your reasons. And if your reasons are, if I think your reasons don't add up in my head, then I'll try and explain that to you, say why I think differently. But we will always agree to disagree. But we can't force an injection onto a 12 to 15-year-old who would not give them their left arm or their right arm. It just wouldn't happen. So have no fear, and be aware that this Gillick competence, every final year medical student has to learn this. Every GP to become a GP has to learn it. There's no way you can become a doctor or a GP if you didn't know what Gillick is all about. So that will save you from any unfair treatment by a clinician. Nurses learn this too when they do sexual health clinics or family planning clinics or whatever clinics they run. I just want to reassure Chair, because we really got to get this right, that there is no compulsion in this with children. The only currency is respect to earn the trust. That is the key message we want to give all your friends out there. We will not sacrifice, but if you sacrifice this, when it comes to teenage pregnancy, you won't listen to me. When it comes to drug abuse, you won't listen to me. So we can't sacrifice all the other good stuff we need to do in the health service just because I feel quite stressed out about this vaccine and this virus. The second thing, Martin, we must remember in where we sit is, we mustn't make you part of the establishment. The trust and the loss of confidence from public to the establishment is real in England today, and we see it in the vaccine narrative as well. So we can't make champions one of us. So whether it's the Martin, when Barry works with a lot of the volunteers can't be our voices. They have to be the independent voice championing the cause of vaccine. But if they get too close to me, then they get tarred under the same brush as I get tarred as part of the establishment. So you and I need to keep a healthy distance as well, so that you speak from your own mind and heart, and should not be seen as Wasa's instrument of power or leverage into the arena of the teenagers. And you and I have to respect that, because we shouldn't put pressure on you, because then we lose you, and then we lose your credibility with your generation.
Thank you, Vasa. That was really helpful. And thank you, Kate and Julia, as well, for your presentation. I'm sure you'll be back soon to update us. Although actually this leads us nicely onto the next agenda item. I think Dagmar and I will run through very quickly. But we have spent quite a lot of time talking about the 12 to 15 vaccines and also the booster vaccination. So what this paper is asking the group for agreement on is whether we can extend this subgroup for an additional 3 meetings, so that we have the opportunity to agree our approach to both of those, but also to post-COVID syndrome, otherwise known as long COVID. So originally, you'll remember that this subgroup was set up to end in April 2021, and then it was extended to August 2021 to focus on vaccination equity. And really, this evening, we're just asking for agreement to extend to March 2022 so that we can agree our approach on the vaccination programme, sort of extended rollout around booster vaccines and also long COVID. So just open up for any questions or comments before we move on to Martin and Lourdes to present on their engagement work with children and young people. Una.
I just want to say I fully support that. It seems very sensible from my reading, and 3 meetings certainly seems very reasonable suggestion. But obviously, the partners, no doubt, have their say. So, thank you.
Una. Mark.
I totally agree. I think yes, the extension of it makes real sense, and I think it is a really useful meeting, isn't it? It's a really useful coming together of minds, and I think that's it's going to be a challenging winter, and we want to continue that.
Great, thank you, Mark. I don't see any dissent, so I'm going to take that as everyone else is happy to continue until March next year. Great. So that then leads us on to our last agenda item, which will be a really interesting presentation from young inspectors Martin Lourdes on their insight work with children and young people. So I will just hand over to them to start their presentation.
Hi everyone, thank you for having us. Today we're going to talk about the Merton COVID-19 Young Community Champions. And yeah, so I'm going to be presenting this with another young inspector, Lourdes Moreno.
Hello.
With me. There she is. We want to talk about the impact of the pandemic on young people, the importance of testing, vaccine information, planning for the future of engagement with young people, and some young inspector reflections that we have.
So how has the pandemic affected young people? Atina from year 7 said that during lockdown, it was a harder learning process. I prefer going to school because I see my friends, get to socialize and go to clubs. Thankfully, I was supported by my family during lockdown and did not fall behind with my learning. I hope to reconnect with others this summer. Whilst Yasmin said that the pandemic has meant I've had to do online school and sit in front of a screen for 6 hours a day. However, I continued Taekwondo online through Zoom, running and went on long walks with my family in the woods. It was overall such a surreal experience, and she is from year 9. Next slide, please.
We also, in our YAC sessions, we also discussed about how the pandemic impacted young adults, and we found that young adults had difficulty with feeling isolated and alone. It was hard not seeing friends and managing stress levels. Also, the reality not matching expectations, like for example, the furlough scheme not covering their full wages, and also changing university from doing face-to-face to having to do it online. There was also some champions felt more prone to depression and anxiety and were having a hard time coping. But other young adults said that they were grateful for healthy family and friends, and also for the amount of time they had to spend on their hobbies. Yeah. Next slide.
Thank you. So these are responses based on the survey conducted over the summer by the under 18s, Toby and Anna, and our fellow young inspectors. So some responders said that they do tests frequently due to work, whilst others tested once a week or not at all. Others said, I do not do a COVID test. I would do it if teachers asked me to bring it in, or if there were rewards or incentives. many young people reported that they would be more likely to do the LFD testing if they did not have to stick something up their nose or down their throat, which is something that Barry had mentioned earlier. There are now testing based on saliva, so that you don't have to stick it up your nose or down your throat. Majority of the 19 young people surveyed understood why testing remained important, and they were doing tests as required. Thank you. Next slide, please.
Yes, and I think the other thing about our engagement is we actually found out that young adults were very curious about the effectiveness of different vaccines like the AstraZeneca and Pfizer. There were general questions related to the symptoms of the vaccine, the risk of blood clot, fertility, reinfection rates, and the impact on the immune system. I think most importantly, young adults wanted to access information and have more clarity around the data. For example, explanations around the efficacy percentages of different vaccines. They also said they wanted clear and consistent communication. For example, it's safer to have the vaccine than not. The overall feedback from the champions that we collated over the sessions were that they also wanted to know about training, volunteering, and employment opportunities. As we know, that's one of the impacts for this particular group, is that a lot of people didn't manage to get their first jobs and weren't able to proceed in employment. A lot of the times they were actually let go. They also wanted to know how to improve other areas of their health, such as sleep, physical activity, diet, and stress management, so they can adapt their lifestyles. I think one of the sessions we run as well, we decided to team up with Towards Employment, which delivers Merton's Youth Employability Project. And we wanted to highlight opportunities related to like CV support and one-to-one support in general, but also like different employment opportunities they're going to have in radio, media, in the rail industry, and with Just Eat. But similarly, we also invited along MVSC, now Merton Connected, to kind of explain the different volunteering opportunities available, and kind of highlight the importance of work experience and volunteering to gain the confidence and experience to move into paid work. Oh, next slide, please.
Thank you. So suggestions for the future. Young inspectors suggest that you expand on current programs that encourage the voices of young people in Merton. For example, the My Health Merton is a project started by young inspectors, where young inspectors created a criteria so that health providers could grade themselves, and then they would receive an award based on their catering abilities towards young people from my Merton or young inspectors. Another way is that you could listen and co-create in the planning and delivery of projects aimed at young people and the wider community. For example, tomorrow we have a presentation done by Toby and Rebecca Glide for the DAA, which is a Dementia Association community, where we will be doing a transgenerational project so that we can help each other. Thank you so much. Next slide, please. So the young inspectors and what they have learned. Martin and myself learned to adapt and be flexible while facilitating in workshops, such as the Why Vaccinate webinar done in May earlier this year. We collaborated with some of the CCG colleagues and members on this board, such as Dagmar, Mohan, as well as others. Anna and Toby learned new ways of engaging with young people through new methods, such as using or engaging with the 18 to 30s group, and also through video, as they've made quite a few videos which can be found on Merton's YouTube page. Next slide, please. So in terms of discussion, we want to ask you, what do you think you can do to support Merton's young residents who are worried about coming back into lockdown this autumn?
Yeah. What are you doing to promote employment training and volunteering opportunities in Merton?
And how do you plan to listen to young people's voices and co-create solutions for the problems young residents are facing today? Thank you.
Great, thank you both, and thank you for that presentation. We might ask you to put that last slide back up to answer some of those questions, but before we do, did anyone have any initial sort of questions or comments on the presentation that Martin and Lourdes shared? Julia, and then Ellie.
Hi, sorry about that. Yeah, I just wanted to say thank you to Martin and Lourdes for the presentation. I thought it really set out some of the kind of work and the insights, but I think what it didn't do was sort of talk about some of the practical work that's been undertaken. So the group of young inspectors have done some fantastic work setting up an under-18s COVID champions network through schools, and I've done a huge amount of work creating videos and resources and the webinars. So I think what you've heard is the insights and that's come out of that, but perhaps they didn't say as much about actually what had gone into to get that, you know, that voice and that understanding.
Thank you, Julia. Ellie, and then Dagmar, and then Una.
Yeah, I was going to make a similar comment about a lot of what we have achieved so far is because of, you know, Lourdes and Martin and their colleagues and the work that they've been doing. And so, yeah, the challenge is right as to what we could do more, but we need to make sure that it's all still co-designed with the young people and with the new young inspectors that we've got in the CSF team who can add some, not going to say it, but, you know, you guys have been around for a couple of years now. They're even younger, so they can give us different insights, and we need to listen to those too. But thank you for your work.
Thanks, Ellie. Dagmar?
Yeah, I just wanted to also, first of all, say thank you. And for me, a bit of a reflection, not to underestimate, even having you, Martin, as a regular on this subgroup, it does change the way you remind us simply by your presence, but then often more than just your presence. The odd questions, the really probing questions, the commentary. So therefore, the proposal or question to this team, how are we setting ourselves up going forward with having you around the table, is for me a really legitimate question, because it, as I said, as it changes the dynamics and dialogue. And so therefore, it is a first very important step. And I'm looking also to our CCG colleagues. There's a lot of changes hurtling down the way. We work locally together. Everybody talks about collaboration, and I'm very, very keen that we turn the aspiration into some concrete long-term ways of working. So having youngsters around the tables where serious, tricky decisions are made, the ones with trade-offs, not just on one side young people having a wish list and saying we want X, Y, and Z, but you sitting with us around the table, listen to the legitimate difficulties and trade-offs and help us finding solutions. So treating you as, you know, equals. That's what I think we should challenge ourselves as a subgroup to progress.
Thank you, Dagmar. So Una, then Barry, Mark, and Vasa.
I would just like to thank you both for that. I think it's very good. I've certainly listened to a lot of the work that you've been doing on the COVID champions regular meetings that we have, and it's been very good and it's been very valuable, and I think bringing that work here as well is good, and hopefully ongoing. As a councillor, it'd be great to have some of you on groups such as the scrutiny panels on the council, so you know, I know we've talked about that before on some of the panels, like the children and young people's panel, but some of the other ones too. You know, there's the environment region, and those sort of areas of work would be great to see more from your cohort and on the young people's side, to ensure that young residents are having a good voice. So I know the Youth Parliament is what works as well, but some of this is very valuable, I know, for the council's work and all the partners. So thank you for your involvement, and it's valuable, and the work you're doing. So thank you.
Absolutely, thank you, Una. Barry.
Thanks, Martin and Lourdes, for a really interesting presentation. And your content and the presentation of it is fabulous. And I've used some of the images that you've produced in wider sessions that I've kind of delivered with the community as well. So thank you for those. I was kind of respond to your final point was about how can we co-create with you. And I'd love to spend so much time with you, but I need to kind of bear in mind there's probably lots of people want to speak to you, but there's some real opportunities that we're designing new projects just about to start now around young people social prescribing. We've got a fabulous social prescribing program across the borough. We're looking to pilot something for young people, potentially thinking about green social prescribing, using those assets that we have within the community. Community testing clearly came up in the presentation, so but I'd love to pick your brains on how we can improve and listen. But also thinking about health on the high street. So there's a new opportunity coming through about how we can deliver health and care and preventative services in different settings, such as the high street across the borough. So again, there's a whole list of bullet points I've written down, which I'd love to speak to you about. So maybe we can add it to the long list, and then Julia and yourselves can kind of say which ones we need to prioritize to make the most of your very valuable and expert time.
Barry. Mark.
Just to echo all the other comments, I think it was a fantastic presentation, and just I think it was really refreshing to actually get the experiences of young people and the insights of young people. So I think it's kind of like spurs you on, doesn't it? It's quite motivational. I think the 3 questions you ask are really difficult questions, and we should all accept them. As Dagmar says, there's a real challenge here because we've got you and we should absolutely use you as much as we possibly can. So I think one of the things that we do need to think about is you are a limited resource. So actually, how does Barry and my team and everyone kind of use you most effectively without tiring you out enormously? Because I also have a list like Barry's. I think as well as vaccinations, we've got things like young people's mental health. It would be great to really plug you into some of the ideas and some of the thinking that's going on, but also for you to direct some of that thinking, for you to actually be some of the power behind some of the actions that we get to. So I think it was a great presentation. Thank you very much.
Thank you, Mark. And Vasa. Oh, sorry, Vasa, you're on mute.
Thank you. As Mark was saying there, in the health service, we use the word commission, i.e. we spend a lot of money to look after young people. Now, when we spend a lot of money looking after you, I think it's rational now that we know of you and of the brilliant work you and your team are doing, to come to you and saying, okay, we are thinking about, like Mark was saying, mental health, sexual health, contraception, well-being, whatever we're talking about for young people. Now we can involve the voice of young people in the design and the delivery. And also what Dagmar said, the difficult decisions sometimes we have to face up to, because we can't do everything for everybody everywhere. And where we have to say no and where we say yes, it'll be good for you to be part of the discussion, because you will have ownership of what happens and you'll have consequence of what happens. And therefore, it's important that you're part of the decision-making process. And we have to bring you into the equation. We can't do things to you and then tell you to trust us, or tell you to take us as credible at face value. We have to earn that. And I think that's what we have learned during COVID, that as a key, going back to the communities who we have struggled to immunize, to vaccinate, is because we hadn't built that bridge, the road, and gained people's trust and confidence. So we can't make the mistake again and again and again. We're going to learn from it. So we will come to you, and I know that there are not many of you, but I think we need to expand your friendship group, if you can call it, if I am allowed to call it, because we need more of you, and therefore we need more of you there, so that I can come to you for something, and Dagmar and Barry can come to something. God, what we can't, we have to prioritize, but we can't cut it down too small, because it'll become meaningless. And I think that's, to me, as I put it out there, you have built a platform. If Facebook built a platform, they'll be charging me for it or selling adverts. You have built a platform free of charge, and you're offering it to us, whether it's in the borough or whether it's in the health service. You are offering your platform free of charge to us, your time and all your effort and all the commitments you bring into this. So it's our job now to build a building on the platform, the foundation you have built, and make it work for your generation. And don't forget climate change. That is your inheritance from me. You may not like the inheritance I'm giving you, but that is your inheritance from me. And therefore, for that debate, I think Dagmar and Yanish certainly have got some plans on that. And you really need to hear your voice louder than my voice at that meeting. Well, I'll be gone in 20 years. You won't be.
Thank you, Vasa. And just to sort of close this off, just to echo my thanks as well to you. And it sounds like we have some really clear next steps on co-creation, and this conversation will keep going, but also the action as well. So hopefully we'll be able to have you come back to the group. And Lourdes, did you want to come back in and leave any final comments?
Yes, I just wanted to say thank you for the opportunity, and it would be great to keep having these conversations, and we will be in touch with you guys to let you know our way going forward. And apologies from Martin, he's finished all of his data, so he's not able to stay on the call with us, but thank you so much, guys. Really appreciate it.
Great. Thank you. And that brings us to the end of our agenda, dead on 6:30. Thank you everyone for your contributions and for your time this evening. And I look forward to seeing you all at the next meeting.